if that makes sense. So my name is Dr. Ahmad Basirat, and I have been working in Ireland for a good few years at this stage, and this is the perhaps the second time I'm conducting the part one exam preparatory course with the Med Exam Expert. It's a very good platform, I would say, and I'll be mentoring the upcoming the December diet of part one through the Med Exam Expert. So today, the basic purpose of giving you this an hour session is just to kind of prepare and demystify your queries and questions regarding MRCPI, and in particularly part one, because obviously that's the first step to start your journey towards gaining the qualification. So this is the Royal College of Physicians of Ireland building. As you can see, it's an excellent place to visit if possible, and it's a building, you can never get tired of seeing the surroundings inside the building, the rooms and the museum as well. Okay, so let's go on to our main kind of roadmap, and I hope the pen is working. Yeah, it is. Yeah. Okay, so the basically the MRCPI examination entry, it basically starts off with part one, which is the first part of the written examination. So in total, there are three parts. So we have part one, then we have part two, and then we have part three. So basically, part three is the clinical part. It's also called as part two clinical or OSCE examination. So starting off with MRCPI part one, which is the MCQ written part. Basically, there are two. If you pass the exam, obviously you can go towards the part two. If you don't pass the exam, you have 6 attempts in maximum to resit for the part one examination. It doesn't matter, how much score you have obtained, if you fail in one of the attempt, because it's all about, in the end of the day, is all about passing the exam and not the actual score. If you understand what I mean to say. So if you fail the exam one time, you have maximum then 6 attempts. So basically 5 attempts then to resit for the part one. And if you still fail after 6 attempts, then it generally it says no further attempts are allowed after the sixth attempt. Um, the next step is obviously if you pass the part one exam, then you move on to the part two. The part two then again is the MCQ written part. If you pass that, you move towards part three. If you don't pass it, then again, same criteria, maximum 6 attempts are available to sit for the part two written again, and no further attempts are allowed after the sixth attempt. Sorry, can you mute your mic, please? Sorry. Sorry, can you mute your mic, please? Thank you. Okay, so if you pass the part two written, then you move on to the part two clinical, which is also called part three. So it's all clinical examination, and this part of the exam, obviously you have to go to a center to sit for the exam, and we'll talk about it later on, that where you can sit for the exam. So if you pass it, obviously then you move towards the completion of your MRCPI, and then you just wait for the MRCPI conferring ceremony. If you don't pass it, then again the same criteria, you have maximum 6 attempts to resit for the clinical exam, and no further attempts are allowed after these 6 attempts. So generally speaking, this is the roadmap for the three parts of the MRCPI. Okay. Um, we move on to kind of, the number of attempts just one more time. So basically, candidates who are sitting for the MRCPI examinations will be allowed a maximum of 6 attempts for each component. So that basically in total makes 18 attempts in total. So part one written 6 attempts, part two written 6 attempts, and part two clinical 6 attempts. Sorry, can you mute your mic, please? Um, Sorry, can you mute your mic? Sorry, guys. If you're able to, if all participants can mute their mic, please. Okay, thank you. Okay, so for example, if we say that a candidate must pass the part two written examination within 6 years of passing the part one examination, if a candidate has attempts remaining for part two written, but the 6 year time limit has expired, a candidate must resit and pass the part one before attempting the part two. I hope it makes sense. Okay, so the entry requirements in generally, a lot of candidates, quite, they put in queries and they ask me about how somebody is eligible to sit for the part one written examination. So generally, we say that what RCPI actually has kind of obviously posted that candidates for the MRCPI General Medicine Part 1 examination, they are eligible to apply 6 months after they have received their primary medical degree. So that's kind of like is the bottom line, to apply for the Part 1 examination. Candidates must have passed MRCPI Part 1 General Examination. No, that's basically for the part two then. So for part two, they say that candidates must have passed MRCPI part one or part one pediatrics examination or have obtained an exemption. So I'll show it to you what exemptions are in order to make you eligible to apply to sit for the part two general written examination. So application is one thing, but generally, they're not too strict. But obviously, in the end of the day, it's the college decision to make you eligible to sit for any part of the examination. But generally, they're not, too strict in these in the criterias. And then obviously then we come toward the third part, and which is candidates must pass the part two general written examination before applying to enter the clinical, which is the part three examination, unless they have been granted an exemption. And there are some exemption. I'll tell you later on in the next coming slides. Okay, so these are the exemptions which make you eligible to become exempt from part one only. Okay, so this is basically the list of the qualifications which make you eligible to be exempted from part one only. Okay, so these are the qualifications which include if you have MRCP UK, all three components. So you can skip the part one written examination. Or you have MRC Path, MRC PCH, FRACP, or FRCP, FCP, MRCP Psych. So these are all, or you are from Kuwait Boards of Medicine and Pediatrics or Oman or Saudi boards. So these are the qualifications which can make you exempt only for the MRCPI Part 1. And two more, including is American boards in General Medicine and Pediatrics and Malaysian board. So, and there is only one qualification which can make you exempt from part two written examination, obviously, which means that you will be exempted from part one as well, and that is FRACP. Okay, I hope that makes sense. And then we say candidates claiming exemption must include, obviously, the attested certified proof of this qualification with their application. And that basically includes number of kind of attestation certifications. You just need to attach those while applying for one of the exemptions criterias. The exam location, when we talk about for the part one and part two written, is basically they are online. So it's very comfortable and very nice just to sit from your home or your home country to sit for these examinations. And trust me, it has made a lot of obviously difference in candidates kind of obviously preparing and then appearing for the exam, because you don't have to travel to the exam center to give the exam. So basically, what the college has been, when I say college, I mean to say the RCPI has been kind of using is basically the remote invigilation through their online exam provider, which is called Test Reach. So this is basically an online provider, exam provider, and remote invigilation is allowing candidates to sit the computer-based exam from their own computer. For example, you're at work or you're at home, you're able to, once you are eligible, once you have the eligibility, you get the you pay the fee and the documentation, you are able to give the exam remotely. Candidates are supervised remotely by the invigilators or supervisors throughout the exam. So basically, you are sitting in a secure, quiet environment in a room, and then there's some criteria, obviously, that the room is not obviously shared with someone else. The room is kind of obviously quiet, and there are no cameras, and there are no laptops, etc. So they go through the checklist when you actually dial into the exam from your laptop. And then obviously the laptop has to have like a reliable internet connection, a webcam, a microphone. These are all simple things which nowadays every laptop perhaps has it. After conducting the validation checks with the supervisor, that's online, candidates must switch their mobile phones off and put it out of reach. And then in before starting the exam, they might ask you to kind of show that you are sitting your background. Sorry, can you mute your mic, please? All just participants, sorry, just mute your mic, please. Thank you. And then obviously in the end, they allow you to start the exam, and then you just kind of scroll through the MCQs. So we'll talk about it a little bit more in the next slides. How do they spread the questions in part one based upon the specialities? This is a general criteria which kind of the college has been using, is the main systems, which include cardiovascular, endocrinology, gastroenterology, hematology, nephrology, neurology. So as you can see, and rheumatology. So as you can see, these kind of main systems, they kind of tend to include, respiratory medicine as well, kind of 5 to 15 MCQs from the main systems.
كويس.
And then we talk about other kind of anatomy, infectious disease, biochemistry, ethics, genetics, immunology. They overall kind of tend to make 5 to 15 MCQs from these systems as well. And then from kind of infectious disease on its own is kind of 2 to 8 MCQs. Then ophthalmology is kind of 0 to up to 3 MCQs. And then, so they generally tend to follow this set criteria for making MCQ. So one paper with 100 the MCQs, it's 3 hours duration, delivered via remote invigilation. There is no negative marking, which is good. At least what they say is that 75% of the questions will involve direct clinical care of inpatients and outpatients. So most of the, as you can see, that like a at least like 3 by 4%, like 75% of the MCQs involve our day-to-day interaction with the patients, either whether they are as an inpatient or whether they are in an outpatient setting. So it's quite kind of close to what we practice, in our day-to-day basis. Correct answers will be within up-to-date guidelines, and as you know, that guidelines do change from time to time, so they tend to kind of make it as close as possible to whatever is available in the most up-to-date guidelines at that point of time. Similarly, when we talk about the part two written, the paper, the spread of kind of questions in part two, as you can see, the main kind of specialties including cardiology, endocrinology. So again, the same thing. The main specialties kind of carry kind of 10%, whereas the minor, such as dermatology, infectious disease, oncology, toxicology, they kind of include only 5%. The rest of the ones are kind of like 10% of the exam. So two papers in part two instead of one paper, which was in part one. In part two, we have two papers, and each paper has 75 MCQs. In part one, the paper was of 3 hours, but in part two, each paper is of 2.5 hours. And it's delivered by remote invigilation. There is no negative marking. Questions may include photographs of clinical findings. Now, in part two, this is one of the things that they kind of tend to include more images and more data interpretations, like maybe interpretation of a arterial blood gas or an ECG or perhaps like a CT image, kind of like the major findings in, as in kind of like a bleed or when we're talking about a CT brain. Data interpretation, some retinal photographs as well. Total combined mark is 150 here. As you can see that there's 75 MCQs, so total is 150. And it's not required to pass both papers individually, but it's considered as an overall score considering the two papers. And then a little bit about part two clinical as well, because this is like a roadmap, rather than just focusing on obviously part one is like a roadmap. Once you start off with the part one, you actually just start the journey, towards the clinical, obviously, which is the last part of the exam. So the clinical examination must be completed. So basically, you have to obviously do the part one and the part two, and then they must be completed to be eligible to be conferred as a member of our RCPI. MRCPI General Medicine Clinical Part 2 examination, for example, ability, they basically assess the ability of a candidate to take the history, perform clinical examination, formulate investigations, and a management plan. So basically from start to scratch. So, on obviously the patients which are in front of you. The clinical examination consists of 2 long case stations and 5 short case stations. So this is how the exam is conducted during the day, in the day. So there are 2 long stations, 5 short stations, and the candidates will have approximately 2 hours to complete the examination, to go from one station to the next, and then you hover around all these stations, and then you're able to complete the examination. There's a 2 hour kind of like the course to complete the examination. The long stations, when we talk about, candidates are required to examine kind of 2 patients for 25 minutes each, so that kind of makes like, so 2 patients, 25 minutes each, as you can well imagine, and the candidates will be observed for 20 minutes while they're taking the history, they're performing a focused and directed examination. And then obviously the last 5 minutes of that 25 minutes is basically for discussion with the examiner, in which, the examiner obviously listens to the history and, talks about the case. The 5 short cases stations, basically in this, candidates will be examined by 5 independent examiners, 1 for each station, and each station is for 10 minutes. And in that, there is the kind of like the quick thing is obviously to be eligible to interpret and pick up the physical signs in various clinical systems. There are 2 types of short cases, so clinical cases and communication or ethics cases. So it will be either, so there will be 5 short cases in which 4 will be clinical, and then 1 either will be communication or ethics. That's the general, most of the time, that's what the routine is followed. Okay, so that's mostly kind of about the part 2 clinical, which probably skip this slide because we are kind of like more focusing on part 1. That's again for part 2 clinical. You can obviously, get this information from me later on as well after we start our course. Going on to the exam fee and the visa. I suppose for part 1, And part two, written examinations, you don't need a visa because obviously you're doing it remotely. You do need a visa, obviously, if you need a visa to travel to give the part two clinical examination. So if a candidate requires a visa to sit an examination, it is a responsibility of the individual to ensure the visa application is made in sufficient time before the examination date for which it has been sought. The college has no influence in guaranteeing or refusing the visas, but of course, the college you can ask for a letter or confirmation of the exam payment, which you can attach with your visa application. When we talk about the fee, so you need to kind of go on to the RCPI website because it is regularly updated to see how much the fees required for the examination. This is the upcoming schedule for the part one, part two, written and clinical. It's available on the college website. The next date is of part one is perhaps coming in December. So that's probably one which we are aiming to prepare you for. So that's on 11th of December, and remote invigilation. The opening date for the application is on 27th of August. So basically was on 27th of August 2025. They're still open if you want to enroll and pay the fee to become to get your seat in the exam. The closing date for the application is 22nd of October. The exam fee is 710 euros. You probably have to convert it from your currency in which country you're paying from. And the results, the provisional date they have mentioned is 9th of January. So you can see that even if so let's say you appear for the exam, you pass the exam, so it's 9th of January. That actually means that you can actually aim to give part two examination in the March sitting, which obviously will be in March 2026. So January results come, you pass the exam, you can aim for the March or you can aim for the June. So that's how they kind of like designed to go from part one to part two written and then to the clinical. So MRCPI Clinical International location, just wanted to tell you guys about this as well. So Jeddah, Saudi Arabia, Riyadh, Oman, Malaysia, UAE, Bahrain. So these are kind of like, the locations for the part two clinical examinations around the world. And of course, it happens in Ireland as well. If someone is here and or someone wants to come here to appear for the exam. How our med exam part one course, how I have kind of designed this along with the team of med exam experts, it's very exam oriented and exam targeted. So we will deliver the course via online lectures. Lectures will be live. They won't be obviously you will have recorded lectures afterwards, but I will. Sorry, can you mute, please? Sorry. Okay, so I will be delivering lectures, live lectures. There will be a schedule which will be circulated to the candidates who will or have enrolled in the part one course. I plan to give, I think we're looking for around 15 to 16 lectures, kind of covering all the part one course. And then this time we have introduced three kind of like a flash kind of review, three sessions which only will be MCQs after we finish off with the whole of the part one course. Each lecture will be delivered over a duration of 2 hours. So live Q&A sessions. You can ask, obviously, as we are discussing the topic. MCQ sessions, we have a Telegram group as well, so we can obviously communicate. The candidates, students can communicate with myself and with the team on the Telegram group. Then the 3 MCQ workshop at the course completion, which I've already told you. Continued support and guidance is provided, throughout the course. There are a few pitfalls which kind of like gathered as the time went on with a lot of obviously background experience and knowledge, that it all kind of comes down to these kind of main pitfalls, which include, I would say pitfalls which lead to obviously your failure in the exam is basically poor time management, or taking too much time on one question. Um, Revision is the key thing. So lack of revision, not simplifying the last 1 to 2 weeks before the exam date, lack of confidence, scoring less than 50 to 60% marks on the mock exams. So we do have a lot of material is available on the MedExam platform, but obviously the mock exams as well. I'll share it to you the resource for that as well. So scoring 50 to 60% less than kind of 60% marks in the mock exam, poor night's sleep before the exam day, and then not paying close attention to the question stem, kind of like the main kind of 1 or 2 words in an MCQ, which include kind of initial, most, or not a likely cause, or first step, or accept. So these are kind of like the tricky things which these are put into the MCQs, and candidates try to kind of skip those and go on to the wrong answer. So I would like to talk about COPD and asthma, if that's okay, and just wanted to kind of give you like a brief overview and the way I will be conducting the course, and simple words just to get a little bit of flavor of it. So when we talk about COPD and asthma, so asthma and COPD, obviously, they're two different obstructive lung diseases. The asthma, when we talk about, is mainly childhood, but can happen in adolescence as well, whereas COPD, typically we say after the age of 40. Asthma can be allergic and non-allergic, so this is one thing, whereas COPD mostly is cigarette smoking, 90% of the causes, whereas we can have other causes as well. Stable course of disease in an asthma, whereas insidious onset and chronic over progression over years. Cough is uncommon in asthma, whereas quite common in COPD. And then we talk about diurnal variation, which is kind of like the day-to-day symptoms. So there is a diurnal variation in asthma, whereas it's not too much in COPD. Nighttime waking with breathlessness and wheeze is common in asthma, with uncommon in COPD. Atopic symptoms, these are the allergic symptoms, which are common in asthma, but uncommon in COPD. And when we look at the PFTs, and I'll show you one later on, the obstructive defect is present in both. But the difference is that that obstruction is reversible post bronchodilator when we give extra puffs of Ventolin during the PFTs, in which the FEV1, which is one of the values, it increases more than 12%. Whereas in COPD, it's a fixed obstruction, it's not reversible, and post bronchodilator FEV1 over FVC ratio is still less than 70%. But the main things to remember for you guys is that it's a fixed airway disease and it's not reversible. The first line medication in asthma are steroids, whereas in COPD are bronchodilators. But we'll talk about it more. How do we classify this kind of like this obstructive lung disease in kind of mild, moderate, severe, very severe? So as you can see, the basic thing here, if you look at the FEV1 over FVC ratio, they are the same. So once it's less than 0.70, we say this is obstructive lung disease. Then we move on to see the FEV1 value. And FEV1 is the forced expiratory volume in 1 second. So if it is 80 or more than 80, it's mild. 50 to 80 is moderate. 30 to 50 is severe. And less than 30 is very severe. So that's how we categorize mild, moderate, severe, very severe. So that stays the same. The main kind of based on classification is based on the FEV1. So if it's mild, it's 80 or more. Moderate is 50 to 80. Severe is 30 to 50. And very severe is less than 30. I hope it makes sense. COPD, then we follow GOLD criteria. That's the international, a lot of MCQs come GOLD criteria. So GOLD is the standard, is basically a committee and the organization which basically categorizes COPD in 3 main classes. So class A, class B, and class E. And that is all based upon the symptoms and exacerbation history. Okay. So if someone has 0 to 1 exacerbation or flare up, not leading to hospitalization, we say either it is A or B, class A or B. How do we differentiate is with the MMRC score, which I will tell you later on. So that's basically a symptom score. So if that is 0 to 1, it's A. If that is 2 or more than 2, it's B. Now, class E is only when you have two or more than two exacerbations or one or more than one exacerbation leading to hospitalization. So they say you have class E. So in class E, the symptoms don't matter that much. It's only the exacerbations. So the exacerbations are very important. Okay, so and then we say goal 1, goal 2, goal 3, and goal 4. And if you remember, if you can recall the previous slide, so 80 or more than 80 was mild. So that is goal 1. Then 50 to 79 was moderate, it is goal 2. Then 30 to 49 was severe, it's goal 3. And then less than 30 was very severe, it's goal 4. So that's how we do. And then, as I told you before as well, we start from FEV1 over FVC ratio of less than 0.7. Hence, we say this is obstructive lung disease, and we move on to the classification. NICE basically obviously is UK based, but we do follow NICE a lot, and the NICE recommended considering diagnosis of COPD in patients over 35 years of age who are smokers or ex-smokers. And then particularly, obviously, they need to have exertional breathlessness, cough, and sputum. The following investigations are recommended in patients with suspected COPD. So the first is lung function test. As I've already told you, you need to have FEV1 over FVC ratio of less than 70%, which shows you have airflow obstruction. Second, chest X-ray, it will show hyperinflation, okay, maybe bulla or flat diaphragm. These are the kind of like the main things you will see in an X-ray for a COPD patient. When we check the bloods, it's basically you can say FBC is full blood count, or you can say CBC. That's the same thing. So FBC or CBC, what it will show is it will show hemoglobin is up, which can be secondary polycythemia. So you can see secondary polycythemia, and that's because of the hypoxia. And then the BMI, obviously you need to see the BMI, and then severity of COPD is categorized using FEV1. I've already told you into kind of mild, moderate, severe, very severe, and gold 1, 2, 3, 4. The FEV1 value alone is used to grade the severity of COPD once the diagnosis is established. So that can be one of the MCQs, that in order to see the severity of COPD once it's diagnosed, how do we assess the severity? That's based upon FEV1. Okay, but it is not a part of diagnostic criteria. So that's basically just to assess the severity, but not the diagnosis. The diagnosis is based upon one of the things here, which is the ratio. Okay. A little bit about asthma. So asthma, we actually follow the GINA guidelines, and GINA basically is another international committee and organization which kind of focuses more on the asthma. And what does GINA tells us is we need to manage asthma in a stepwise fashion. So step 1 to 2, then step 3, step 4, step 5. So starting off with asthma, the salbutamol or the Ventolin inhaler, they're no more recommended anymore. So we start from low dose ICS formoterol. If that is not responding, we move on to step 3, which is basically we go from low dose ICS formoterol to low dose maintenance ICS formoterol. So here you are using it only as required, which is called PRN basis, or as required basis, not regularly. Whereas in step 3, you can see you need to use those regularly. The same thing, but regularly. And then the step 4 is we basically go from low dose maintenance to medium dose maintenance ICS formoterol. And then the step 5 is you add a LAMA, which is basically a leukotriene, muscular, which is the antagonist, which include the ipratropium or Atrovent or so this LAMA, just to kind of let you background, please. Sorry, can you mute in the background, please? Thank you. So this LAMA is basically a drug which comes in the first step of management of COPD, whereas you can see this is coming in the last step of management of asthma. So that's the difference between COPD and asthma management. So step 5 basically said that we add on LAMA and consider high dose maintenance ICS formoterol, plus minus, you can think about using other drugs such as anti-IgE or anti-IL-5. Anti-IL-5 are the novel drugs nowadays which are used for the management. We can talk about it in detail when we go through the respiratory system. Now, in terms of asthma, obviously, you can say we have moderate, severe, and then life-threatening asthma. And these are the kind of main things. Some MCQs have been made based upon the classification of the asthma. There is a fourth category as well, which is called near fatal asthma. And the near fatal asthma is basically only when you see a raised PCO2 on the blood gas or an ABG, or requiring mechanical ventilation with raised inflation pressures. So moderate, severe, life-threatening, and then the near fatal asthma. This is as per the BTS guidelines. This is the lung function test I was talking about. I don't think that will come obviously in part one, but it perhaps can come in part two. And then, obviously, but the main values you probably are looking for in a full PFTs is whether there is obstruction. This probably starts off looking at the FEV1 over FVC value. I marked those in the box there. So you look at this value. So this is 55 less than 70, which means this is obstruction. You go on to FEV1. You say this is 50. So as I've already told you, 50 to 80 is moderate. So this is moderate obstruction. Then you see that this is the reversibility part. So you can see that, so we were talking about 12% reversibility in FEV1. Here, this is 21% reversibility. So this is reversible. So most likely we are dealing with the case of asthma here. But then you go on to the second part, which is the lung volumes and diffusion capacity. I can talk to you about later on when we go through the respiratory system in the lectures. So overall, in this PFTs, you can see there's an obstruction, moderate obstruction, positive reversibility, reduced gas transfer. This is gas transfer, so that's reduced. So this is basically consistent with asthma COPD overlap. Okay, let's do a little bit of brainstorming as we are going towards the end of the presentation. So if you can put your answers in the chat box, and I just want to kind of have a feel and assess where you guys kind of like stand in terms of your preparation or your plan towards the MRCP. A 65-year-old man with a 50-year history of smoking, okay, presents due to increasing breathlessness. A diagnosis of COPD is suspected, okay? Which of the following diagnostic criteria should be used when assessing a patient with suspected COPD? So I'm talking about a diagnostic criteria. Number one, FEV1 more than 70% of predicted plus FEV1 over FVC ratio of less than 60%. Number two, FEV1 less than 70% plus symptoms suggestive of COPD. Number three, FEV1 less than 70% plus ratio of less than 70%. So here ratio was less than 60%. Here ratio is less than 70%, but the FEV1 is less than 70 here. FEV1 less than 80% and the ratio less than 60. And the last option is FEV1 less than 70% and the ratio more than 70. So I'll give you maybe like 2 minutes to think about it and make a selection of the answer and put it in the chat box, and I can discuss with you the answer then. Okay, so most of you are saying the option is 2. Okay. Okay. So a few answers here. They're saying the option is 2. So you're talking about this option. So where the ratio is less than 70% and there are symptoms suggestive of COPD. Okay. And one person is saying, let me ask ChatGPT. Well, you probably won't be able to get that in an exam. Okay, let's go to the answers. Okay, so the correct answer is yes, you're right. So at least like 3 or 4 people there are right in answering. So the correct answer is ratio less than 70% plus symptoms suggestive of COPD. So the NICE guideline tells the diagnosis of COPD requires both the presence of symptoms, which are breathlessness, cough, sputum, winter bronchitis, wheeze, and airflow obstruction, and the airflow obstruction on spirometry, and that's enough for the diagnosis of COPD. The key spirometric criteria for COPD is a post, but when we say the key spirometric criteria for COPD is a post bronchodilator FEV1 over FVC ratio of less than 70%. The FEV1 value alone is used to grade the severity of COPD. As I told you earlier on the slides, the FEV1 is only to assess the severity of COPD, not to diagnose it. Okay, so good. Let's go to another MCQ here. A 20-year-old girl attends the emergency department with a 4-hour history of shortness of breath. Okay, so very short history, and she has asthma. Okay, she was treated with oxygen, magnesium, Lama Laba nebulizer. So it's quite severe, as you can see, somebody's requiring magnesium. Despite treatment, her respiratory rate is 35 liters per, 35 per minute. Saturation is 93%. Heart rate is up. Temperature is okay. Her peak flow is quite down, 40% of the predicted. She cannot complete sentences, and there is a widespread wheeze on examination. So an ABG is shown here. So let's see, what do they show in the ABG here? So pH is 7.37, so that's normal. PaO2 is 10, that's normal. Okay, reasonably good. PCA2 is 4.9 kilopascal. Now, I know people working in different countries, they have millimeter of mercury in their blood gases, whereas in Ireland, we use kilopascals. So perhaps, I really hope, like, you will get millimeter of mercury kind of in the exams as well, but you might need to convert these to millimeter of mercury, just making you guys aware of that. So PCA2 4.9 kilopascal, and lactate is normal. So basically, they're asking that how can we categorize this severity of asthma? Either this is severe, life-threatening, mild, moderate, or near fatal. So let's give you 2 minutes and we'll go through the answers then. Okay, so some of you are saying it's 2. Okay, so you're talking about life-threatening. Okay, fair enough. Okay, so most of you have already answered 2. Okay, so let's go through the answer. So this is, yes, so this is life-threatening we are talking about, and the main things kind of is normal PCA2 here. And then another main thing obviously is the oxygen saturations are, it's 93 there, but the main thing is this peak flow, expiratory flow is less than 33% as well. So you can well imagine that the reason of them giving the ABG was basically to assess your knowledge that if you have an asthmatic attack and if you have a normal PCO2, that basically is pointing towards a life-threatening asthma. Okay. MCQ number 3. Which one of the following is the main criteria for determining whether a patient with COPD should be offered long-term oxygen therapy? Okay. So the options are 2 ABGs with PaO2 of less than 6.3, 1 ABG with PaO2 of less than 7.7, 1 ABG with PaO2 of less than 8.3, 1 ABG with PaO2 of less than 8, or 2 ABGs with PaO2 of less than 7.3. Which one of the following is the correct answer? I'll give you a minute and we'll go through the answers. Okay, so some of you already answered here and you're saying it's 5. So you're talking about this option. Okay. Okay, so yeah. So let's go through the answers. So we are talking about long-term oxygen therapy here, and the criteria for long-term oxygen therapy is, so let's see, the answer is, so we need to have 2 arterial blood gases with PaO2 of less than 7.3, and yes, that's correct. So BTS, the British Thoracic Society, the guidelines which we follow is that LTOT, or long-term oxygen therapy, should be offered to patients with COPD who have PaO2 of less than 7.3 in 2 separate measurements. That's important, which are taken at least 3 weeks apart when the patient is stable and medical management. Yes, so the answer is 5. Okay. A little bit about long-term oxygen therapy, that how do we assess it and what are the criteria? So you need to have very severe airflow obstruction. It's important to assess in those patients cyanosis, polycythemia, peripheral edema, oxygen saturations less than or equal to 92% on room air. That's important as well, that if patients have PaO2 between 7.3 to 8, I know you guys understand that it's less than 7.3 LTOT is okay, but if you have between 7.3 to 8 kilopascals PaO2, then you need to have one of the followings to be eligible for the criteria for LTOT. And these options include nocturnal hypoxemia, secondary polycythemia, peripheral edema, pulmonary hypertension. Okay. Okay, let's talk about another MCQ there. A 72-year-old man presents to ED with 1 year history of dyspnea and accompanying dry cough. Okay, never smoker, history of rheumatoid arthritis, currently being treated with methotrexate and no documented history of allergy or atopy. On respiratory examination, an expiratory wheeze is noted and the spirometry shows ratio is 60%. What is the most likely cause of symptoms? So the key things in this MCQ I'm already kind of picking here is rheumatoid arthritis, 1 year history of dyspnea, and he's a never smoker. Okay, so they're the key things. So you're talking about asthma, bronchiectasis, bronchiolitis obliterans, methotrexate, pneumonitis, pulmonary fibrosis. I'll give you a minute and we'll go through the answers then. Okay, let's see what you have answered here. So some of you have picked up pulmonary fibrosis. Some of you have picked up bronchiectasis. Some of you have picked up bronchiolitis obliterans. So there's a variety of options people have selected. Okay, good. You're trying. That's good. Your brain is working. That's good. What is most likely cause of his symptoms? Okay, let's talk about the answer. The answer is bronchiolitis obliterans. So these MCQs, these kind of MCQs are very easy to answer. And I tell you why, because you need to pick up the key things which are in these MCQs. So one of the key things here is rheumatoid. One of the key things is never smoker. And the last key thing is a year history of dyspnea. Okay. So if you have these clues in the MCQ, especially the rheumatoid arthritis, the option is bronchiolitis obliterans. Okay. Now, why is this? Because the patient's history of rheumatoid arthritis with symptoms of dyspnea, cough, wheeze, obstructive pattern on spirometry is strongly suggestive of bronchiolitis obliterans. And this condition is recognized as one of the pulmonary complications associated with rheumatoid arthritis. Okay. People who have selected obviously pneumonitis or pneumonitis, this probably presents like more like an acute thing, not with a history of 1 year history of dyspnea. But it's good that you guys are thinking, your brain is, kind of hovering around the options. And then, of course, asthma is not appropriate diagnosis here. There's no documented history of allergy or atopy. Okay, perhaps the last MCQ I would say, you are reviewing the management of a number of patients with COPD. Which one of the following factors should prompt an assessment for LTOT? So I'm talking about an assessment here. Okay, so if FEV1 is 54%, hemoglobin is 18.1, BMI is 18.8, oxygen saturation of 93, the ratio of 0.47. Okay, I'll give you a minute. We'll go to the answers. Okay, so some of you have selected hemoglobin, some of you have selected oxygen saturations 93, some of you have said polycythemia, fair enough. Okay, some of you have selected body mass index, BMI, hemoglobin. So mostly you're hovering around hemoglobin. Okay, good. You're doing a bit of brainstorming there. Okay, so the answer to this MCQ is the hemoglobin of 18.1 is the correct answer. And I'll tell you why. The raised hemoglobin, basically we're pointing towards polycythemia here, in a COPD patient suggests chronic hypoxemia and should prompt the assessment for LTOT. That's long-term oxygen therapy. Secondary polycythemia develops as a compensatory mechanism to chronic hypoxia, increased erythropoietin production, leading to increased red blood cell production to improve oxygen delivery to tissues. This option is incorrect, and that is because the cutoff is 92% on room air, not 93%. So we say less than 92% perhaps. So the answer is hemoglobin of 18.1. It's just wanted to share you, very interesting lung function test. And I recently came across this while, I was doing the ward rounds, and This is a very interesting flow volume loop here. As you can see that this is, so normally generally what we say, this is the inspiratory loop and this is the expiratory loop. So the normal shape of the inspiratory and the expiratory loop is like this. So you can see that this is actually gone way down than what it should be. So when we talk about these, you probably say these are flattened inspiratory and expiratory, they're flattened. So when we look at the spirometry, that was a normal spirometry, normal lung volumes, normal gas transfer, but the fluid volume is very flattened. So it was pointing towards the fixed airway obstruction, and this patient had a tracheal tumor. So there was a tumor inside the trachea. So, so when we only did the PFTs, our brain started to work, saying that it could be a tracheal tumor. And that actually turned out to be a tracheal tumor when we were doing the bronchoscopy. So that was something I wanted to share with you guys. I found it interesting. Thank you very much for listening today, and I hope I clarified hopefully a lot of things in regards to the MRCPI road journey. Nothing in life is to be feared, it is only to be understood. Now is the time to understand more so that we may fear less. Thank you. I'm happy to answer any questions if you want to post in the chat box, or if you yeah, sure. Yeah. So Dr. A is saying few questions would like to ask at the end. Sure, perhaps. Yeah, go ahead. Okay, so what are the differences for general medicine and internal medicine pathways? Thanks, Ramesh. So they both are the same, basically. GIM or IM, I'm talking about Ireland, it's the same. So this MRCPI is basically a general medicine degree qualification. They both are the same. Which resources should we use for MRCP Ireland? Well, perhaps MedExam Expert is an excellent platform. There are live sessions, MCQs, but if you still want to still think that you're lacking, you might can use extra resources such as Past Medicine, On Examination. These are also kind of like good resources to study from. Okay, so sorry there. Uh, okay, so what about else you want to ask? Passing mark out of 100 in part one. They basically use what the college basically uses is, to my knowledge, is they use it's called relative marking, or it's not that every MCQ carries equal marks. Perhaps it's some way they design is that they do this as a very fair marking system. So there's no, let's say in one diet the passing mark is 50%, in the next diet it might be 45% or it might be 70%. So it depends upon the overall performance of the candidates who have sit in the exam. That's my understanding. um, so I wouldn't be able to tell you what is a passing mark is, because it just depends upon, varies from diet to diet. And about international residency pathway, if for Saudi and Bahrain citizens only. Sorry, I didn't get that question. Um, Pass medicine or on examination or pass? Well, perhaps if you're talking about part one, I would suggest, as I've already said, our course, our platform is excellent, but pass medicine, probably I would say, and on examination, in for part one. If I'm training in a pre-clinical specialties, I'm going to biochemistry, will there be a problem in the channel? Sure. What about, sorry, it's a bit tricky questions about the training pathways because obviously, we are mainly particularly dealing with the preparatory course for the MRCP Part 1 exam here. What about English language test? Well, I don't think you need an English, you don't need an English language test to sit for the MRCP Part 1 exam or Part 2 written. I don't think so, not to my knowledge, unless you find something changed on the college website. Is it possible to get into general medicine training after passing MRCPI? Well, I suppose your chances to get into the training schemes are better after obtaining the MRCPI. Yes. What are scoring criteria? Well, I've already answered this. What about FCPS cardiology? I don't think there is an exemption for FCPS cardiology. You can have a look. I did share it to you guys in one of the slides, the exemption criteria for part one and part two. The moderators can share those with you as well. The med exam, if you can, if you're able to contact them, and there shouldn't be a problem. Sir, I have appeared in August, September. In my opinion, if I'm more than 70%, I'll not be going for what was the passing mark. It depends. Passing mark varies from diet to diet. There is a detailed mark sheet where probably you have gotten it, and it should stay there. The passing mark score. What is it? Yeah. Sorry, I'm not aware of the exact passing mark because obviously it varies from diet to diet. There's a detailed exam score you should have gotten after your as a result from the college. I think, well, I look. I think if you guys ask that, should we do both pass medicine and on examination, or should we do one, or should we do pass medicine on exam and pass test? I don't think there is a limit to prepare any exam in the world. I have given almost a lot of different colleges and exams, and but I would suggest that targeted and to the point preparation is always the best. So I would say if you start obviously with the MCQ banks, perhaps past medicine is kind of like a little bit better than on examination. Look, but this is my opinion. Don't quote me on that. But okay then for. Will your course include banks of BMJ on exam? I don't take MCQs or code, from any of the banks. I kind of, try to be very exam targeted. So kind of, it takes a lot of obvious time to brainstorming and putting in a lot of things into the presentation. So I don't think, there is any particular one resource, I use to, pick up the MCQs from. Um, okay. So they probably okay. Um, there. Um, I suppose the support service from the Met exam is excellent. They're sharing the WhatsApp and Telegram support numbers if you want to ask any further questions. Get in touch with them. And our course for the part one, we are hoping to start it in September this month. And we are hoping to end it at least 2 weeks before the exam date in December. So that you can have a little bit of time, obviously, of your own time to prepare and to gather all the thoughts and to prepare to sit in the exam. So I look forward to seeing you all, in the course, actual live sessions, and we'll make our journey together, and we'll try our best. Okay, all the best, and best wishes from my side. Thank you.